us. Like he said, my name's Jen, and I'm going to be presenting today with my colleagues Dayla and Sarah, and we're all stewardship pharmacists at CHI Health, and our presentation will be the use of clinical decision support systems to enhance the role of antimicrobial stewardship. Our objectives for our presentation will be to review the regulatory requirements and the available clinical decision support systems for antimicrobial stewardship, implement antimicrobial stewardship interventions using clinical decision support systems and electronic health records into our clinical workflow, and to utilize reports generated from clinical decision support systems, or EHRs, to support AMS activities and interventions. A little bit of background on this topic. Antimicrobial stewardship standards and regulatory requirements are increasing with the demands on healthcare systems to meet. Antimicrobial stewardship activities have been shown to optimize antimicrobial use and clinical outcomes while decreasing costs, and that's been published a multitude of times and something we're all well aware of. However, information technology incorporated into antimicrobial stewardship practices can lead to improved efficiency and effectiveness and help us reach those regulatory requirements that are increasing. So the CDC has provided core elements of antimicrobial stewardship for hospitals, most recently updated in 2019. And they note that key support is needed for various areas for successful antimicrobial stewardship in hospitals, but that includes IT staff. So some examples of IT support that they give for antimicrobial stewardship would be to embed relevant information and protocols at the point of care, implementing clinical decision support for antibiotic use and creating prompts for action to review antibiotics in those key situations, and facilitating and maintaining antimicrobial use and resistance reporting. There are other areas that they outline as key support that's needed, and that might include clinicians, nurses, department leaders, P&T committee, infection prevention and hospital epidemiologists, quality improvement, patient safety and regulatory staff, and of course our microbiology lab. Moving on to some of the current regulatory recommendations, CDC does have two areas that they recommend in their core elements, and they highlight tracking and reporting. So for tracking, they recommend monitoring antibiotic use through reporting to the NHSN network, antibiotic use module, or days of therapy per 1,000 patient days. As far as reporting goes, they recommend sharing summary information on antibiotic use with leadership, providers, pharmacists, and other healthcare professionals. And we'll be getting more into the capabilities that you can learn on for reporting later on in the presentation. The Joint Commission also has requirements, and these new recommendations will be effective January 1st of 2023. And their recommendation is that Antibiotic Stewardship Program monitors the hospital's antibiotic use by analyzing data on days of therapy per 1,000 days present or 1,000 patient days, or by reporting antibiotic use data to the NHSN antimicrobial use option of the antimicrobial use and resistance modules. So these two, CDC and Joint Commission, have very similar recommendations as far as that goes. As far as clinical decision support systems, there are two common types of systems that you can look into. So there are EHR-based systems. The availability and functionality will vary between types of EHR, and they usually are an add-on purchase for stewardship-specific modules. They may not be part of your baseline EHR setup. Our examples of most commonly used EHRs that I'm sure you're all aware of would be Epic, Cerner, and also Meditech. There is also the option to do an add-on clinical decision support system, and this is going to run parallel to your EHR. It's dependent on data that can be extracted from the EHR, and it's going to be data that flows one way from the EHR to the add-on CDSS. Examples of this would be Century7, Theradoc, and Vigilance. So there are two separate types of systems, and they both have their strengths and limitations. So when we look at the EHR, some of the strengths are that there's less initial interface development when setting that up. So of course, all of your data is already there within the EHR and embedded, so there won't be the IT component there. The AMS recs are accessible to a provider at order entry, potentially. You have one centralized system for communication and documentation, and you have better access to retrospective administration and clinical data. As far as limitations within the EHR, tailoring rules and alerts requires more IT input initially and long-term, so you're gonna need a hospital IT team with a lot of support. It offers less end-user customization and less real-time adaptability. And then stewardship programs may require the additional purchase, like I mentioned before. And this is typically a limited option for resource challenge settings. When we look at add-on clinical decision support systems, their strengths are that they are low-cost alternatives for resource-challenged settings. They have real-time adaptability. The rules and alerts can be modified with little IT support. The version can be standardized across multiple institutions, and they're end-user friendly. As far as limitations, like I mentioned before, it is a one-way data stream from the EHR to the add-on CDSS, so it does require more IT work up front for validation to ensure that the data flow is appropriate and crossing over. Toggling between multiple systems does make for a less efficient workflow for the stewardship team. Updates to the EHR need to be tailored to the add-on CDSS also, and they might not always be aware. There might be a slight update to Epic, for example, and then that might throw off your Theradoc. So good communication between those two teams is important. And then less retrospective data is going to be available, readily available. And duplication or omission of data from the EHR is always of concern. As far as the practical role for clinical decision support systems in antimicrobial stewardship, it will help improve efficiency and effectiveness of your daily workflow and activities. It could be used to track antimicrobial utilization and clinical outcomes, and it also could help evaluate opportunities for improvement through well-built reports that you can run on a regular basis. Some examples of daily stewardship functions within clinical decision support systems would be empiric antimicrobial selection. You could look at generating automatic stop orders, managing prior authorization, restrictions, and non-formulary, promoting initial empiric therapy that's appropriate based on the infection type, and selecting the appropriate dose, indication, and duration upon order entry. There's post-prescription antimicrobial review, so you could have alerts for an antibiotic timeout, organism-drug mismatch, duplicate therapies, duration of therapy alerts, evaluating culture results in relation to antimicrobials, IV to PO, and dosing adjustments. Diagnostic testing stewardship, which is a huge component of our job. You can build alerts for important labs such as procalcitonin, rapid diagnostics, and micro results. So if you're getting blood culture results, getting an alert built so you're alerted in real time when that goes positive. Reduction in urine cultures for asymptomatic bacteriuria, and appropriate C. diff testing. Communication is also something that you can incorporate with a daily handoff or transitions of care. And then you can also look at syndrome-specific management where you can provide best practice alerts to optimize and minimize therapy, electronic notifications to facilitate that real-time optimization for potential interventions. Now I'll hand it off to Dayla to discuss the clinical workflow in real-life setting.
Okay, thank you, Jen. So as I've been introduced, I guess, multiple times now, my name is Dayla. I'm one of the Antimicrobial Stewardship Pharmacists at CHI, and we just wanted to share some specific examples of how we incorporate our CDSS and EHR into our daily antimicrobial stewardship workflow. As Jen previously mentioned and has been mentioned multiple times today, in 2019, the CDC released a great resource for the core elements of antimicrobial stewardship. And within this document, experts list what they consider the 3 priority interventions, which include prospective audit and feedback, pre-authorization, and facility-specific treatment guidelines. For prospective audit and feedback, what this means is it's an external review of antibiotic therapy performed by an expert. And this is usually done at some point after prescription of the antimicrobials, accompanied with suggestions to optimize use. And this is really what our team is responsible for with our daily antimicrobial stewardship rounds. The second type is pre-authorization, and this is requiring approval prior to the use of certain antibiotics. This is helpful to optimize use while also preventing unnecessary initiation of targeted antimicrobials. And although drug cost sometimes plays a role in this, that should not be the focus. The focus is really to optimize use. The last priority intervention identified by the CDC are facility-specific treatment guidelines. And this helps both enhance prospective audit and feedback as well as pre-authorization processes, and helps establish clear recommendations for optimal antimicrobial use. So let's dive into some examples of how we meet these priority interventions. To identify actionable stewardship interventions in my workflow, I rely very heavily on our clinical decision support software, we partner with Theradoc. As Jen mentioned, there's multiple different companies, but this is an external add-on program outside of our EHR. I have, all three of us, I believe, subscribe to email alerts for what we have identified as high priority results. And this, your top screenshot here is an example of an email alert that is sent directly to my inbox. You don't have to be logged into your EHR. It's a de-identified alert, and then you can go and review the patient within the EHR. But that is sent right at the time of the lab being updated in the EHR, so real time. I also have daily alerts and reports built within Theradoc to help identify patients that would benefit from stewardship intervention. So this bottom screenshot here is an example of an alert on one of my reports. This specifically triggered a bug-drug mismatch. So you can see the patient had a urine culture that grew out Enterococcus, and the antimicrobial they are currently on is ceftriaxone. So that would not treat that particular organism, and I would then flag that in my EHR as a list of patients to intervene on for that day. There we go. As Jen mentioned also, there are multiple different types of alerts that you can build. Most of these programs are very customizable. This is just by no means an inclusive list. These are just some of the most common ones that I review daily. They can fire based on microbiology results, bug-drug alerts, or based on the antimicrobial order specifically. And then I have put an asterisk on those that I also subscribe to email alerts. So all positive blood cultures, C. diff, our MDR pathogens like ESBLs and CREs, all of those would get forwarded directly into my email or inbox to review in a timely manner. We also additionally throughout our system have all of our BioFire blood culture IDs get routed to our EHR Epic in basket for all of our pharmacists to review 24/7. So once I've identified patients that would benefit from stewardship intervention, I will then flag those within the electronic medical record. So that's kind of that toggling back and forth between programs like Jen mentioned. But this is just an example of how I have my patient lists organized within Epic. I really wanted to customize my list to make sure that I could see the most important stewardship information at a quick glance. So it's not super easy to see from here, my apologies, but I have which hospital, which facility the patient is at, because we each cover multiple facilities, as well as which unit they are on, patient name, the attending, their active antimicrobials, a creatinine clearance, so you can at a quick glance kind of do a dose check. Also days of antimicrobial therapy, any allergies that they have, if they have an active isolation order in the computer. And then discharge order signed, I find that one very helpful. A little green bubble will show in that column if the patient is going home for that day. So I will try to prioritize reviewing them sooner rather than later so I don't miss my chance to intervene. It's always more complicated after they're discharged. One other function that I find extremely helpful in my workflow that's available within Epic, I'm not sure about other EHR systems, but there is a option for a column called My Sticky Note within Epic. And so this sticky note is visible only to me, and I'm able to take notes in that section that if there's not like a pre-built column for that. So I'll put all of my microbiology results, any like follow-up tasks that I want to do if I'm waiting on a lab. And what's really nice is that we'll follow that patient's MRN. So if they move rooms, if they move hospitals, like often happens in our health system, or if they're discharged and readmitted, on first glance when I'm scrolling through my patient list, I can say, oh, that's my patient that just discharged last week with MRSA bacteremia, and I know what their treatment course was, and make sure that we can follow up on them quickly. So if you have that available within your EHR, it's extremely helpful, and it's just visible to to you, so you don't have to worry about leaving confusing notes for your colleagues. As far as pre-authorization, we do have appropriate use criteria or restriction criteria for what we consider targeted antimicrobials within our system. This is a formal policy that was approved through Antimicrobial Stewardship Committee as well as P&T. All of our criteria is built within our EHR, and so you can see here in the screenshot, it will display upon order entry to the ordering provider. And our process for that, this responsibility to review appropriateness falls on all of our pharmacists upon order verification. This is not something that just stewardship does. It's a consistent process 24/7. We utilize smart phrases within our EHR that build the criteria into a checklist for the pharmacists. And this simplifies the process for those interpreting the criteria, allows for consistent and complete documentation for all pharmacists, regardless of their comfort level with infectious disease, and keeps it consistent throughout our system. This is just an example of one of the smart phrases that we have built. This in particular is for our remdesivir appropriate use criteria. So we were able to build this. We have different criteria, a different checklist, depending on whether or not a patient's requiring supplemental oxygen. So what we were able to do is there's just one smart phrase for remdesivir, but the very first question is going to ask the pharmacist if the patient's requiring supplemental oxygen. Depending on it, whether they answer yes or no, the rest of the note is going to pre-fill with the correct criteria for that indication. So then you can see it's just kind of a checklist. They can go through yes or no and then give some instruction if a patient falls outside that criteria. And that documentation helps even if sometimes they're shot down on trying to switch to an alternative. It's very helpful for us when we come back the next day and we're doing our stewardship review to have documentation to know what the conversation already was about why this antimicrobial was ordered. Lastly, the CDC identified a priority intervention as infection and syndrome-specific interventions. They specifically list out the most common disease states that we see in hospitalized patients. So community-acquired pneumonia, UTIs, skin and soft tissue infections, MRSA, C. diff, as well as culture-proven invasive infections. So we have a lot of documents and guidance out there to try to steer providers in the right direction, but it really seems to work best if you just go ahead and incorporate that into the EHR in some sort of order set build. So this is an example of the antibiotic section of our sepsis admit order set. And you can see the patient's being admitted under this broad diagnosis of sepsis, but then we have them select what they think the suspected source of infection is, which then will guide them to which antibiotics are most appropriate. And then we also offer alternative antibiotic regimens for patients with allergies to make sure that they're getting comparable coverage and making sure that it's still targeted and appropriate. I also want to point out it's important to include your other diagnostic tests, so any micro that you would want, blood cultures, sputum cultures, an MRSA NAIRS, culture PCR, procalcitonin, anything that would be helpful to de-escalate antibiotics throughout the course of the hospitalization. And if you can, pre-check them on your order sets, so then it would require them to uncheck it for it not to be done. And that'll just kind of help you throughout the hospital stay. Another example of order sets, we have a division-wide surgical prophylaxis guideline, and this was built out into order panels within Epic that then feed into all of our perioperative order sets based on procedure type. So this helps ensure adequate dosing, timing, and duration. It'll have hard stop on your post-op antibiotic orders, and also ensures consistency. So if we update that surgical prophylaxis policy, we only have to go in and update that panel, and the updated panel will then feed into all of the order sets, as opposed to trying to track down every single order set. In addition to our more antimicrobial stewardship team-based interventions, the CDC does call out other healthcare professionals that can help with stewardship. So some provider-based interventions, you can consider antibiotic timeouts at 48 to 72 hours of therapy. Ways that you could incorporate this into the EHR would be like a best practice alert pop-up to providers, or an antibiotic soft stop that they would have to kind of renew just to make sure that they're checking it daily. Just to point out, these don't necessarily don't necessarily reduce overall antibiotic use, but they do tend to improve appropriateness of antibiotic selection. So not quite as effective as more targeted stewardship interventions, but important nonetheless. And also having providers help assess penicillin allergies. We all listened to that great presentation this morning about how terrible our antibiotic allergy documentation is in our medical records. So just making sure that there's an adequate history and physical examination, challenge doses, skin testing, and really documenting in the EHR on that allergy if a patient has tolerated beta-lactams previously, or delabeling them entirely as deemed appropriate. And that will carry forward. Oh, sorry guys. Okay, some more automatic pharmacy-driven interventions. These are not limited to stewardship. This is the expectation of all of our pharmacy staff. We have automatic IV to PO policies, dose adjustments, especially our renal dosing policy, dose optimization protocols such as extended infusion beta-lactams, duplicate therapy alerts, automatic stop orders, drug-drug interactions. All of those can be built in your CDSS and can be incorporated into the workflow of all of your pharmacy staff. Microbiology-based interventions, again, I feel like I'm kind of just repeating some excellent presentations we've had this morning, but having selective reporting of antimicrobial susceptibility, as well as comments in your microbiology reports. So this is an example of how our laboratory identifies an ESBL organism, which basically just confirms everything that we just heard during our last presentation. So. Lastly, some nursing-based interventions. Nurses can help with optimizing microbiology culture collection. We have a checklist within our EHR anytime a C. diff is ordered for the nurse to make sure that that is appropriate and makes sense clinically. It will flag if a patient is on any laxatives or tube feeds or anything else that could be contributing to a patient's diarrhea. They also have checklists for appropriateness of continuing or discontinuing a Foley catheter, appropriate culture collection in a catheterized patient to make sure that if we are sending specimens that we can interpret those appropriately. They can also assist with pharmacy and providers on IV to PO transitions, as well as prompting antibiotic timeouts and asking if antibiotics are still indicated or if we could make a change. All right, I will turn it over to Sarah, who will talk about some reports.
So I will be reviewing some different reports that could be generated from the EHR or the CDSS to support and demonstrate antimicrobial stewardship activities. So first, I'll discuss the days of therapy per 1,000 patient days, which is an example of an antibiotic use report. So this uses the days of therapy for an antimicrobial divided by the number of patient days for that facility. This can allow for standardization to compare different sized units or facilities. 1 day of therapy is counted for a patient regardless of the number of doses of a single antimicrobial a patient receives, which is advantageous with the different PK/PD dosing schemes or renal dose adjustments we use for our patients. This data can be used to demonstrate the effects of an antimicrobial stewardship intervention by trending the use over time, and we can also combine the days of therapy for multiple agents based on the bacteria targeted or the specific class. So this image is an example of a report generated from Theradoc, where I pulled the days of therapy per 1,000 patient days for the top 25 antimicrobials at an institution. Theradoc also gives us averages, unique administrations, and unique patients. We also have a link for the specific patient details, so you can pull a list of the patients that are on that antimicrobial for that period of time. And this entire report can be exported to Excel or to another program for additional analysis or chart creation. Alternatively, instead of the top 25 antimicrobials, we're able to select specific antimicrobials. So as Dayla mentioned, we have use criteria for several antibiotics, and so we're able to pull that list and look at the utilization of those specific antibiotics. So this chart is an example of a combined report for our most common anti-Pseudomonas beta-lactams. So this shows a sum of the days of therapy per 1,000 patient days for cefepime, meropenem, and piperacillin tazobactam, and the trend over time at several facilities, which are represented by the different colored lines. This is also an example of how you can export the data from the CDSS into Excel and create different graphs that may be more useful to your specific program rather than relying on what the CDSS provides only. Next is an example of using days of therapy graphs to demonstrate the effects of an AMS intervention. So this graph shows linezolid use over time at a specific institution with 2 different interventions marked. There's also a trend line that shows a decrease in use over time. So it was helpful for me to follow the days of therapy, especially after the first intervention, to see that another targeted intervention was needed with specific providers and provider groups so that we could continue to optimize our linezolid use at this institution. Excuse me. So another type of antibiotic use report that's been mentioned several times can be generated following submission of use data to NHSN through the antibiotic use module. So some electronic systems, so either your EHR or CDSS, allow users to submit that data directly to NHSN, which they will then generate the standardized antimicrobial administration ratio, or SAR. And they also will generate days of therapy per 1,000 patient day reports. And this also allows comparison between different facilities since it's benchmarked by NHSN based on the size of the facility as well as the different types of populations. Can consider discussing this option with your specific vendor if interested in pursuing this. There are many ways to illustrate the work pharmacists and other healthcare professionals do to support AMS activities. The first example I will show is IV versus PO reports. So most facilities do have pharmacist-driven IV to PO protocols or policies, and setting a benchmark goal for the percentage of those highly bioavailable agents given orally versus IV can help encourage that conversion. So these graphs look at IV versus PO doxycycline. The first graph looks at this as a percentage of a whole, and the second graph is looking at the sum of the days of therapy per 1,000 patient days. We could also look at this data based on the percent of orders or the percent of administrations. However, by using the days of therapy per 1,000 patient days, we're able to compare across our different facilities or different units rather than there might be, different numbers of patients in different units. The second example would be looking at antimicrobial use by specific indications. This works best if providers are required to enter an indication upon order entry and if this data is readily retrievable from an electronic system. These kinds of reports allow analysis of adherence to facility or national guidelines for a specific indication and for targeting specific antimicrobials which may not be routinely recommended for some indications, as I will show with fluoroquinolones on the next slides. So this first graph looks at the percentage of patients who had antibiotics for UTI that were receiving a fluoroquinolone. This facility also had a goal set for less than 15% of those prescriptions to be a fluoroquinolone. In response to not meeting the goal, the pharmacy team removed fluoroquinolones from most order sets and also provided education to our providers about empiric therapy choices based on the local antibiogram, as well as how to handle patients with penicillin allergies. So as shown here, following this intervention, we were able to meet that goal of less than 15%. The second graph looks at fluoroquinolone use for 3 indications that had been identified as targets for reduction in fluoroquinolone use. So this graph looks at the count of cases rather than the percent of patients, and was helpful for the pharmacy team when we were designing the education, as mentioned before. Finally, data from the CDSS or EHR could be used to generate provider report cards. These reports compare different physicians or groups of physicians to their peers, which can influence prescribing habits. Some potential information that could be included is use of specific antimicrobials, durations of therapy, indication-specific antimicrobial use, or adherence to local guidelines for common disease states. Creating these reports may require export to a different program. I will now turn the presentation back over to Jen for our conclusion.
So to kind of wrap things up, where do we go from here? Your first step would be to consider an IT needs assessment and resource evaluation regarding antimicrobial stewardship and available clinical decision support systems. So what data is accessible under your current model? And then can you make what you have work better than you're using it currently? How easy is it to obtain information in a usable format or upon request? And will this help support increased stewardship initiatives and further improve patient care? So some examples of things you'd want to think about for antimicrobial stewardship specifically: what metrics are available to track antibiotic use? What is your ability to track interventions and acceptance rates, as that's an important part of following how well your stewardship program is functioning. Ability to customize lists for monitoring. Can it identify common interventions such as duplicate therapies, treatment duration, and IV to PO? And is there a dashboard present? And based on your needs assessment, you can further determine if purchasing an EHR module or an add-on CDSS would be warranted or feasible. Of course, there's financial implications with those choices, and you need to consider your IT support and functionality. It is crucial to identify key stakeholders at your institution before determining which CDSS is best for your institution. Other key stakeholders would be ID physicians or physicians with a stewardship interest, epidemiologists, infection preventionists, pharmacists, laboratory personnel, and IT personnel. And they can then help map out the needs for each department. This isn't necessarily just for stewardship pharmacy and pharmacists or physicians. It could be used and beneficial for other departments also. So in summary, clinical decision support systems available for antimicrobial stewardship programs include both EHR and add-on clinical decision support systems. Both of these can be used to help meet regulatory requirements and optimize stewardship daily workflow and patient outcomes. AMS interventions can be implemented in a variety of ways using your CDSS and the EHR in combination, and reports generated from CDSS or EHR data can be utilized to demonstrate the effectiveness of an antimicrobial stewardship program. These are the full reference list. And do you have any questions for us? Does that mean no or yes? Is that a question? Okay. Stay here.
Ladies, that was a great presentation. Thank you. One question, it seems like you all have like a little different spin on the interventions and how you use your electronic health record. At a system level, do you meet regularly to kind of compare notes and kind of like tips and tricks? And how would you consider like orienting a new stewardship pharmacist to use those same things?
We meet, the three of us, twice a month every other week. So we discuss a lot of different things at those meetings. So that's one of the things we intermittently discuss, that things we might notice. One of us notices, brings it up to the other two to see if they've noticed it, and kind of how do we work through that, or how does that person deal with it one way or the other. As far as orienting new stewardship pharmacists, typically, I started initially, and then we expanded the program. So when the others joined, they trained with me for some days, and then ultimately filled out the rest of the group. And then Sarah was our most recent addition, and so she trained with both of us to see kind of our different ways we use our workflow, how we use Epic, how we use Theradoc, and how we kind of intermingle that into our stewardship activities from day to day. Is that accurate?
Yep.
Yeah.
Great job. I had a question, or
Oh, boy.
do you have any comments on some of the challenges with the systems, the integration, and any stories you want to share politely?
That definitely is a challenge. That's probably one of the biggest challenges of doing the add-on CDSS is the when there's upgrades to Epic and different things that just kind of like throw Theradoc off kilter and you don't realize it, and then all of a sudden the data flow isn't working and you got to revalidate and some of that stuff. So that can be kind of hard. I don't have a specific example, but I will say, Sarah might, but I will say in general before Sarah gives a specific example, it can take a lot of time to validate that, so it is a really important step in the process so that you can optimally use the add-on CDSS. And so having the external support from the Theradoc team is really helpful too. And that's why it can be beneficial for people that maybe don't have as robust of a hospital IT department, because you need sort of less help on the ground, and they provide a lot of their, they provide a lot of the help, but it's just making sure that they know the changes that come. But anyways.
Yeah. Do you just use the Theradoc in addition to the capabilities of Epic? I know because it's such a large system that you're working in. I know at our hospital we were using Theradoc and we moved into Epic and transitioned over. And I know some reporting things were easier one way than the other.
Yeah, it's kind of depends on what we're talking about and which works better, but the alerts are definitely all through Theradoc, and so there is that toggling between the systems. We don't have